Joining us today. We're delighted to have this opportunity to present the findings from the Health Research Board funded study on EQUIP relating to medication use in older adults with intellectual disability. So to introduce myself, my name is Maura O'Dwyer and I'm an assistant professor in the School of Pharmacy in Trinity. And I was the co-PI on the EQUIP study. I'm delighted that we're going to have about 30 minutes of a presentation today. Hopefully we got in some really interesting questions before today, so I'm hopefully going to try and address those during the presentation. But then we'll also have about 25 minutes for a panel discussion where we'll be delighted to hear your questions and comments. And for the panel discussion, I'm delighted to welcome and to have here today Professor Mary McCarran. So many of you will know Mary. She is the PI of the IDS Tilda study. She's the current head of the School of Nursing and Midwifery in Trinity College Dublin. And also we have Dr. Rosemary Gowran, and Rosemary is the clinical lead for the National Clinical Programme for People with Disability. So it's fantastic to have Rosemary here as well today. So I'm going to get started with the presentation. So if you have some questions, you can put them as you go along. I won't address questions during the presentation in the chat box, but also it would be great then at the end you can raise your hand for any questions. So just to note, we had a lot of requests to record this session, so we will be recording the presentation, but we just won't be recording the comments and the panel discussion afterwards. So just checking with someone, is that okay to? Yeah, great. Okay, so as I said, the study, and it just finished recently, was called EQUIP, and we here looked at psychotropic use in people with intellectual disability. And today we'd like to summarise how evidence from this study can inform and support policy and practice. So many of you will be familiar with the IDS Tilda study, but briefly for those who aren't, the IDS Tilda study was founded by Professor Mary McCarran back in 2007, and it is the first nationally representative longitudinal study on ageing with an intellectual disability that is comparable to the general population in the Irish longitudinal study on ageing. So this has been a fantastic opportunity for myself as a pharmacist when I did a PhD with the study, and for multiple other healthcare professionals and other professionals to look for the first time at this nationally representative sample of older adults with intellectual disability. And there have been 5 waves of the study to date, with wave 6 currently in planning. So briefly, at baseline of the study, there were 753 participants, and they were randomly recruited from the National Intellectual Disability Database. And this was to ensure that the sample we had was representative in all the key demographics of people with intellectual disability. All levels of intellectual disability are represented, which is really fantastic because historically, often, particularly people with severe and profound intellectual disability were excluded from many trials. The age of 40 and over compared to the age of 50 and over in the Tilda study was selected because of the earlier onset of age-related health conditions and earlier onset of medical conditions for people with intellectual disability, and reflecting their shorter lifespan. All living circumstances are represented, which has also presented a really important research opportunity for us, because as the study has gone on, people have been decongregated or moved from different settings, and this has provided a really good opportunity for us to look at this and the impact on medication. So at each wave, there's a pre-interview questionnaire, a lot of information, including about medicines, and then a computer-assisted interview with a face-to-face interview. So it's a really comprehensive interview process and captures the whole lifespan of people with intellectual disability. And there have been many other add-ons to the study, and also objective measures of health, which was led by Dr. Ailish Burke, which we have used a lot in this study. So as you can see on the IDS tilde conceptual framework, there are just so many components to this study, so much information gathered from such a wide range of areas, including physical health, cognitive health, psychological health, behavioral, healthcare, which includes medication use, and social aspects such as community participation. So when we were planning this study, we really wanted to look at the breadth of data we had in addition to medication data. And very important from the start, even before PPI became important in funding, IDS tilde always had a values framework, nothing about us without us. So really promoting inclusion of people with intellectual disability at all stages of the study and guiding the study. And I'll talk about this a little bit more later in relation to PPI within the EQUIP study. So to give you a brief background around medication use, so when I started looking at the IDS tilde data for my PhD, which is now about 13, I think, years ago, immediately I was struck when we looked at the first wave of data, and this was really the first time that we had national data on a population with intellectual disability. I was really struck, compared to working in a community pharmacy with the general population, just the really high volumes of medication use. And we looked at the levels for a paper in the BMJ Open, the levels of polypharmacy and excessive polypharmacy. And we defined polypharmacy as 5 to 9 medicines and excessive polypharmacy as 10 or more medicines. So while often multiple medicines are needed and indicated to treat multiple health conditions, we also picked this threshold of 10 or more medicines because there had been a number of studies in the UK suggesting that at this threshold of 10 or more medicines, there's a really increased risk of drug interactions, of hospitalizations, and impacts on quality of life. We found that people with intellectual disability, 1 in 5 at baseline, and this really has stayed steady or slightly increased with time. 1 in 5 were taking 10 or more medicines. And when we compared that to the Irish longitudinal study of aging, with the participants over 50, in that population, 2% were taking 10 or more medicines. So we were clearly seeing much, much higher levels of medication use, really increasing the complexity of prescribing. Something else that immediately struck me looking at the data and then analysing it was the different patterns of medication use compared to the general older population. In the IDS tilde study at baseline, the most commonly reported classes of medications were antipsychotics, reported by 43% of participants, anti-epileptics, reported by almost 4 in 10, and laxative medications reported by 1 in 3 participants. And again, this pattern of use has stayed relatively steady over time, with laxative use increasing over the waves. And when we compared this to the Irish longitudinal study in aging, here lipid modifying agents and other agents for like age-related cardiovascular conditions were much more commonly used. So a lot of this work led to us applying to the Health Research Board Secondary Data Analysis Award for the EQUIP project. And the aim of this project was to examine the quality and trend of psychotropic use in adults with intellectual disability over a 10-year period, to inform practice and policy, and to improve medicine use and health outcomes. This project was a little bit different from previous projects we had done. We wanted to examine quality and change over time. So we now had 10 years of data that could provide us with really important insights. And we also wanted to look at the possible long-term side effects of psychotropic medications, and if a move to the community means reduction in these use. And I did receive quite, I think, a lot of, those of you who are on the call are very aware of this. I received quite a lot of really good questions about long-term side effects of psychotropic medications, which I hope to address. So this project was really exciting for us because we had a collaboration with the HSC program, the newly formed National Clinical Program for People with Disability, and the Learning Disability Faculty in the College of Psychiatrists of Ireland. So this was the first time for the medication group that we worked in collaboration with healthcare professionals and with the HSE to really look at this use, to be informed when we were looking at it, and to see how this can influence policy and practice. And this work was also supported, in addition to the management group, by the steering group, by the PPI panel for people with intellectual disability in the Trinity Centre for Ageing and Intellectual Disability, by HSE task group, and by other advocates, people with intellectual disability. So it was a really good opportunity to get lots of feedback. There were 5 work packages, and as you can imagine today, I can really only touch on the surface of them, but I'm open to any questions and possibly having a future webinar if there's one particular area that's of more interest to people. So we wanted to examine the effect of psychotropics on cognitive and physical function over time for people with intellectual disability, to assess the change in psychotropic use over a decade, to assess the impact of change in residence for people on the use of medications and outcomes, and to examine differences in psychotropic patterns for 40 to 49-year-olds in wave 1 compared to newly recruited 40 to 49-year-olds in wave 4. And an overarching aim was to ensure patients and key stakeholders, such as the HSE and the College of Psychiatrists, were involved in a meaningful and informative manner. So our study protocol was published in the Health Research Board open research outlet, and this was very important that we had everything set out in advance, what we would do and what we would plan in a very systematic manner. Our work package 1 aimed to examine the effect of psychotropic medications on cognitive and physical function over 10 years for older people with intellectual disability that partook in wave 1, 2, 3, and 4 of the study. So this spanned from 2010 to 2020, so a decade of data. We analysed the association of exposure to psychotropics and risk of falls, cognition, so tests of memory, chronic constipation, and functional status as measured by an index called the Bartel index, so whether people needed assistance in daily activities. And these outcomes were selected due to lots of previous research that found associations between psychotropic use and these outcomes been particularly important because of the impact they would have on people's quality of life. We published this paper in the British Journal of Psychiatry Open just this year. And some of the key findings, so there's quite a bit going on in this little graphic, but the top yellow line signifies at each time point the number of people who were exposed to any psychotropic medication. And these were defined as antipsychotics, antidepressants, anxiolytics, hypnotics or sedatives, and mood stabilizing antiepileptics in the absence of an epilepsy diagnosis. So you can see here over the 4 waves, there was very little change in the number of people exposed to a psychotropic. So at each time point, over 6 and 10 were exposed to a psychotropic medication. And this really underlined the need for the study, that what is unusual compared to the general population is that the majority of people with intellectual disability in the study were exposed to at least one psychotropic and often more than one. Some other points of interest from the study. So antipsychotics for people who remained in the study stayed relatively stable over time, over 4 and 10 people reporting an antipsychotic at each time point. There was a significant increase in antidepressant use. So at 2010, 28% were reporting an antidepressant. This group in 2020, 35% were reporting an antidepressant. But there were some substantial decreases, particularly in the anxiolytics. So that decreased from 1 in 4 down to 17% by 2020. And also the hypnotics and sedatives, 14% were taking one in 2010. This was down to 9% in 2020. So these were really kind of positive signs, and we're doing more work looking at this, but we think some of this, and we'd welcome your feedback, is a reflection of changes in the general population associated with these types of prescribing. Women were more likely to report antidepressants compared to men, and this reflects similar to the general older population, where women are more likely to report depression and antidepressant use. Living in a residential setting, even adjusting for other confounders, people were more likely to take a psychotropic. Those who had severe or profound intellectual disability were more likely to take hypnotic sedatives or antidepressants. Having a mental health condition, those were more likely to take any psychotropics. What was quite interesting when we did our models, and Dr. Marina Odalovich and Dr. Ashley Gorman did fantastic work putting together very complex statistical models to look over the 10 waves of data and to see the influence of taking 2 or more psychotropics and if this impacted on outcomes. Again, we deduced that taking multiple psychotropics would increase risk of these outcomes. So people who were more dependent on each other for help, on others, for help, were more likely to take 2 or more psychotropics, but we didn't find a significant association with having a higher risk of falls, reporting constipation, or getting a new diagnosis of dementia. So it's not to say that the medications aren't associated with it, but there are also other factors. In work package 2, we analysed the medication data from the IDS-TILDA study, and for the first time had the opportunity, we had received consent from a subset of participants who wished to consent to this, to link their medication to the HSE PCRS dispensing data. So many of you might know the Primary Care Reimbursement Service gathers dispensing data from the pharmacies each month, from the main schemes, mainly for the purpose of reimbursement, but it is also used in research. And this data for us was fantastic. It was the first time it had been done for a national population with intellectual disability, and really showed us how valuable and accurate the data we have gathered is. We found almost perfect agreement between antipsychotic and antidepressant use, between the self-reported data we received and what was reported in people's dispensing records, and substantial level of agreement in the other components. We noted no change in the number of people reporting different mental health conditions between wave 1 and wave 4. So there was a slight decrease, but it wasn't significant. And again, here at nearly all time points, over half or up to half of people with intellectual disability are reporting a doctor's diagnosis of a mental health condition. So this is just something that's really significant and really important for us to investigate. There was a significant difference in the prevalence of the psychotropic subclasses, as I've already mentioned, with significant decreases over time in sedatives, but a substantial increase in antidepressant use. We examined the levels of care people were receiving for mental health, and this is something we plan to look at in more detail in future. So at wave 1 of the study, 43% of the total population said that they were receiving psychiatric care. So this tallied quite well with the number of people who were reporting a mental health condition, and this had slightly decreased to 39% at wave 4. In terms of receiving psychological treatment, this remained quite steady over time, slightly increasing at wave 4, where up to 1 in 3 people in the study were receiving access to psychological treatment, and most people were receiving this from a psychologist. Similar with the psychiatric treatment, the vast majority of people were receiving this from a psychiatrist. I had a number of questions from those of you who've joined the webinar around behaviours of concern. And of course, this could be just a topic within itself. I'm briefly touching on it today, but happy to take any questions. So in the IDS Tilda study at wave 4, we did have a structured question about reports of behaviour of concern or challenging behaviour. So we had information on medication, we had information on self-reported diagnosis of mental health conditions, and the team did huge work trying to establish or deduce who was using psychotropics for a diagnosed mental health condition versus who was using them without that diagnosis. And this, we did it as well as we could, but it can't be perfect just due to the nature of the data. So for example, we found among 413 participants who reported behaviour of concern in wave 4 of the study. So again, this is, I think, over 6 in 10 people. So a major issue for people and a major impact on their quality of life. 67% of those were receiving a psychotropic medication. But interestingly, 1 in 3 who reported behaviour of concern that didn't have a reported mental health condition were receiving a psychotropic medication. So we cannot say with certainty what those medications are being used for, but it is likely that in some cases, these psychotropic medications are being prescribed for reasons other than the reported mental health conditions. What was also, and antipsychotics were the medication that were reported most commonly for those with behaviour of concern and those without a diagnosis of a mental health condition. What became really clear in the study, and it wasn't something we had initially thought of and really highlighted to us, the value of having Rosemary and Maeve and other collaborators was the issue around access to non-pharmacological support. So overall, almost 6 in 10 of those who reported behaviour of concern reported access to non-pharmacological support services, so like psychologists or behaviour support. But for those who reported a behaviour of concern and didn't have a reported mental health condition, only 4 in 10 of those participants were reporting access to these non-pharmacological support services. So this really highlighted to us that this picture needs further investigation, further focus, and is complex, that it may be the case that sometimes psychotropics are prescribed in the absence of other options or in the absence of people having access to these really important services that they need in different areas. We looked at the influence of change in place of residence on psychotropic use patterns, and this lovely diagram that's a little bit complex was put together by our data scientist, Abhijay Paul, who did fantastic work on this. We looked at the impact. So we knew through the 4 waves of data, we had lots of people who moved residence, as you would be aware with decongregation. This presented for us a really important opportunity to see how the impact of mainly moves to the community were impacting on medication use. And the literature to date before this hasn't been, substantial one way or the other on what happens in these cases. So for example, at wave 1 to wave 2, we had 31 people who moved from a residential setting into a community group home. And then we also had these groups that are interesting that we looked at called lateral movers. They were people that moved from, for example, one residential setting to another residential setting, or one community group home to another community group home. So for example, here 29 people moved from one community group home to another, and that is a change too. We were interested to see what impact that would have. Just to pick out a few brief highlights of this, at wave 2 to wave 3, we had 58 people who moved from one residential setting to another. And I think it's important to highlight between wave 2 and wave 3, I have it circled in red, we had 30 participants who moved from a community group home back into a more restrictive setting, like a residential setting that may have been a nursing home, or as getting older, having more complex needs. But it's important to also bear in mind when we're focused on move to community settings that there are also people that for different reasons are moving back to residential settings. We looked at the influence of change of place of residence over 10 years on the patterns of use of psychotropics. So those who were 65 or older were more likely to take psychotropics, and this group would be more sensitive to the side effects of psychotropics like falling and daytime sedation. They were more likely to live in community group homes, residential homes, and those who were less likely to take psychotropics were those with Down syndrome and those who moved from one place that was similar to another place. So that didn't seem to be as big a transition, one community group home to another. And again, the story for people with Down syndrome is a little bit different. Professor McCarran might address this afterwards. We are seeing consistently less use of psychotropic medication for different reasons. We looked at the change in the total number of psychotropic drugs over time. And we wanted to look at the characteristics of people who never took psychotropics at the 10 years of the study. And again, these are actually a very important group to see how this group are different. We found that those with Down syndrome were more likely to have never been exposed to a psychotropic. Those who lived in a residential setting or a community group home were more likely to have taken a psychotropic and not be in this group. For those whose psychotropic use increased over the 10 years, we found those with severe to profound intellectual disability or moderate level of intellectual disability had a significant increase. And for those whose medication decreased over time, so I had a couple of questions around deprescribing, which is very interesting. And we can see that this is definitely happening to some extent, particularly with the sedatives and benzodiazepines. So those with Down syndrome were more likely to have a decrease in psychotropics if they were taking them. And interestingly, those with a new instance of epilepsy would be more likely to have a decrease. This possibly could be to do with impacts on seizure threshold of drugs and something that we plan to explore further. We did this with all of the different medication classes, but today I'll just touch on the antipsychotics. So those who didn't take any antipsychotics at all the waves of the study, again, quite an interesting group because almost half of the study population did take them. So those with Down syndrome were significantly more likely to not take antipsychotics all through the study. And they, associated with that, reported much lower levels of reported mental health disorders. Those who lived in a residential setting or a community group home were more likely to take antipsychotics at all points of the study. We had a number of questions around dementia, which we're happy to discuss after the presentation, but those who had a new reported diagnosis of dementia were more likely to have their number of antipsychotics increased when we adjusted for other confounders. The last main work package, we examined the difference in psychotropic patterns between two groups of 40 to 49-year-olds. So a really interesting opportunity presented with wave 4 of the study because we had a new group to replace the group of 40 to 49-year-olds that had gotten 10 years older or passed away. We had a new group recruited in 2020. And of course, this group have grown up in a very different time with less historic institutionalization and possibly medication use. So we were very interested to compare the group from 2010, who were 40 to 49, to this new group in 2020. And we found that less of this group lived in residential settings, and 1 in 3 reported a mental health condition compared to 45% of the group back in 2010. We found overall a significantly lower use of psychotropic medications for 40 to 49-year-olds in 2020. 37% were taking a psychotropic, compared to over half in 2010. And in particular, much lower use of antipsychotics. So 1 in 4 in 2020 were taking an antipsychotic, 4 in 10 back in 2010 of the group. I didn't report it here, but there was actually a similar, if not higher, use of antidepressants. That was the one thing that was similar or the same. for the group in 2020. And we did find significantly lower levels of 2 or more psychotropics. So 23% of the group in 2020 taking 2 or more compared to 35% in 2010. And we have done more work on this that we can also, again, if it's of interest, have another webinar to discuss. But this has certainly been really interesting and along the lines of what we hypothesized before we started this part of the study. So just to finish off, to give you a really brief overview of some of the dissemination work and the participant public involvement work. And this was led by Kiva Leslie and Dr. Ashley Gorman, and Kiva and Ashley are here today. And they did fantastic work to make sure that we kept people with intellectual disability core to our group, and that this influenced the way we conducted the study. So we had a grant from the National PPI Festival on Let's Chat About Medicines, which Ashley organised, and that was a fantastic event. And one of the highlights from it were that many people with intellectual disability who were at the event highlighted that they had never received information about their medications and they were looking for information. We have an Equip website, and after the webinar, we'll send around some links, and this includes a really nice video that we don't have time to show today, but it was led by people with intellectual disability. And I'd really recommend when we send around the link that you all have a look at it if you can and share it with anyone that you think would be of interest to. And that's just some clips from the filming day. So we have Lorraine Keating and Shannon there. They were both advocates who were an integral part of the project, and some of the other PPI panel members as well were involved in the video. Just to give a couple of key recommendations, and I know people asked some questions around this. Now, of course, it's very hard to cover everything, and I certainly haven't in half an hour, but I hope you've found things helpful. There really needs to be comprehensive, regular review of medication use, and I had a number of questions around that to avoid inappropriate prescribing of multiple psychotropics. So we know that sometimes these medications are needed, but they need to be reviewed. There definitely is deprescribing taking place. I had a lot of questions about that. We can see that in the area of hypnotic and sedative medications over time. So certainly medications are being reviewed. The lower use of psychotropics among younger participants is a very positive finding to see, particularly the lower use of antipsychotic medications. And one of our key findings that we didn't really expect and that we need to look into more for the future from when we started this study is the real need for access to non-medication support such as psychological therapies, occupational therapy, social work, and speech and language therapy. And that we need to know a little bit more information, and we are going to do that with wave 6 of the study. But in the absence of access for people with intellectual disability, and the same as the general population and having equity of access, people need access to other supports to support their mental health, even if that is along with medications. Just to acknowledge the Equip management team, which are here. And as you can see, this is a huge number of people that have been involved in the study, and we're really grateful for all their involvement. The TCAID PPI panel, Lorraine and Shannon, our steering group, Rosemary for setting up the task group. We were very lucky to have the collaboration of the HSE-PCRS for the linkage of the study. The participants, families and carers of the IDS Tilda study. So without such fantastic data and input and generosity from participants, their families and support workers, we wouldn't have this data and hopefully be able to help improve outcomes with it, and the Health Research Board Secondary Data Analysis Award. So I think I'll stop my presentation for there and we can